any abdominal pain or uterine contractions. How vitals are stable. The ultrasound reveals a low-lying placenta, partially covering the internal os. What is the most appropriate next step? Okay. The questions you might find easy, but our main focus is on what? On the topic. Okay. Questions, even if you will do gotification, but main focus is on where? On the topic. Now, if I discuss what is the probable diagnosis of this particular condition? Yes? Placenta previa. Okay. Now, my dear students, you already know that hemorrhage is of two types. When we talk about obstetrics, what is obstetrics? Anything related to the pregnancy, right? Now, in obstetrics, we have two types of hemorrhage. What are the two types of hemorrhage? Antepartum hemorrhage and postpartum hemorrhage. Very good. What is the two types? Antepartum, postpartum. What is antepartum hemorrhage? The hemorrhage which taking place before the delivery. The hemorrhage which takes place before the delivery, but after 28 weeks. So examiner can ask the definition. The antepartum hemorrhage is defined as bleeding from how many weeks onwards? From 28 weeks onwards till the delivery. Very good. That is going to be antepartum hemorrhage. Okay. Now next type of bleeding is going to be postpartum hemorrhage. What is postpartum hemorrhage? After delivery. After delivery till anyone? Till 12 weeks. Okay. After delivery till how many weeks? 12 weeks. Sir, any bleeding after 12 weeks or any bleeding before 28 weeks, I will call it as abnormal uterine bleeding. So, क्या बोलेंगे इसको? Abnormal uterine bleeding. Now, if I discuss about this postpartum hemorrhage, बच्चे, if I discuss about this postpartum hemorrhage, sir, this postpartum hemorrhage, you already know, it is after the delivery. But now question is from where? From antepartum hemorrhage. What was antepartum hemorrhage? Before the delivery. Now this antepartum hemorrhage can be of how many types? Three types. Mainly three main causes can be there. First cause is going to be placenta previa. Second one is going to be abruptio placenta. And third one is going to be Vasa previa. Okay. Now three main things that are related to the pregnancy. Three main things that are related to the pregnancy having a cause for antepartum hemorrhage. What are the three things? Placenta previa, abruptio placenta, and Vasa previa. So there can be also fibroid, polyp. There are other causes. But the main thing related to the pregnancy. Why related to the pregnancy? Because all these three conditions are associated with placenta. Now let's learn what exactly is placenta previa, Vasa previa, and abruptio placenta. But before going every question for obstetrics, always there are how many answers? How many answers? Three answers. Why, sir, three answers? Preterm, term, postterm. Condition is same, but the treatment is going to be different. Condition is same, but the treatment is going to be different. So any point of time, whenever you see a question from an obstetrics, the first thing you will look at the period of gestation. Second thing, you will look for the vitals. Are the vitals stable or not? Sir, one thing is basic. Anytime vitals are unstable, anytime mother is in the shock, anytime mother is bleeding, answer is going to be cesarean section. Very basics. Answer is going to be cesarean section, right? So let's learn what exactly is placenta previa. Then we will discuss all the options and the question. Now, what is placenta previa? So placenta previa means when the placenta is implanted in the lower uterine segment. What is placenta previa? When the placenta is implanted in the lower uterine segment. Okay. First, I will discuss a bit, then we will write in just 2-3 minutes. Is that clear? Yes. Now, when we talk about this placenta previa, it can be of different types. Type 1, type 2, type 3 or type 4. Okay. Type 1, type 2, type 3 or type 4. But this was an old classification. What was this classification? Old classification. Sir, either it is lateral, it's marginal, it's partial, or it's complete. How many 4 types we had before? Lateral, marginal, complete, or incomplete. Okay. But the new classification says that the placenta previa can be of only how many types? 2 types. How many types? Two types. One type is going to be, sir, either it is a low-lying placenta. What is low-lying placenta? Sir, it's a 2 centimeter away from the os. Or either, sir, it's going to be type 2, type 3, and type 4. All termed as what? Placenta previa. Are you getting my point? Yes. Again, again, again. So what is placenta previa? So placenta previa means when the placenta is implanted in the which segment? Lower segment. Clear? Now, sir, before the old classification, it was said that the placenta previa can be of 4 types. So either lateral, marginal, partial, or complete. But the new classification says it is of only how many types? 2 types. Now, type 1 is called low-lying placenta. And type 2, 3, and 4 is called placenta previa. Is that clear? Now, the main important part that they will ask is the management. In obstetrics, what is the most important part? Management. Okay, na? Now, tell me, you all know, tell me what is the presentation of a patient of a placenta previa? How the patient will present? First of all, painless vaginal bleeding. Very good. Now, I will ask, you will answer me. Will the uterus be soft or hard? Soft. Tender or non-tender? Non-tender. Period of height of uterus is corresponding to period of gestation or more? Same. Very good. So what is the classical presentation of a patient? Sir, a patient is coming to me with a painless vaginal bleeding. First thing, sir, vitals are normal. Sir, height of the uterus is corresponding to the gestation. Are you getting my point? Yes. Third point, sir, uterus is soft and non-tender. Very good. This is a classical diagnosis of placenta previa. Now, do you understand how the patient will present? Painless vaginal bleeding, soft uterus, non-tender, height of uterus corresponding to the period of gestation. Okay. Now, my dear students, when we talk about this placenta, जब हम इस placenta की बात करते हैं, now what is placenta previa? So, placenta previa means when the placenta is implanted in the lower uterine segment. Now, again, there are 2 conditions. Either the patient will be in the term pregnancy or before the term. Either preterm or term. If a patient is in the term pregnancy and placenta is on the lower uterine segment, it is closed. The door is closed. Can the baby come? Patient in the term pregnancy, there is only one management. What will be the management? Very good. What will be the management? Cesarean section. Excellent. Now, if a patient is coming before 37 weeks, what will be the management? What will be the management? Sir, wait. Sir, conditions apply. Okay, it is not like before the term, always the answer is what? Conservative management. No, it can be cesarean as well. But when vitals are not stable, patient is actively bleeding, maternal is at risk. So any time when these conditions are there, your answer for preterm is also going to be cesarean section. But if patient is not actively bleeding, vitals are stable, mother is at not risk, you will go for conservative management. You will go for conservative management. But sir, conservative management or cesarean section in preterm, one of the most important thing, first I need to check fetal lung maturity. Yes or no? Yes, what I need to check? Fetal lung maturity. Now, how you will check the fetal lung maturity? Anyone? Yes? Yes, lecithin sphingomyelin ratio is 1. What else, online people? Yes, phosphatidylglycerol. What is that? Phosphatidylglycerol. Sir, we check the phosphatidylglycerol in the amniotic fluid. Lungs are mature. If the lungs are not mature, then what you will give? Steroids. What are the steroids you will give? Dexamethasone, betamethasone. First say betamethasone, then dexamethasone. How many doses of beta? 2. How many doses of dexa? 4. So B2D4. How do you remember B2D4? This is again the question. Now, sir, after giving steroids for fetal lung maturity, अब हमने क्या दिया? Steroid for fetal lung maturity. Then we will do what? If vitals are stable, continue the pregnancy. If mother at risk, again go for cesarean section. That is the whole crisp, concise placenta previa. समझ आ गया? Once more, again, I will say. Then we will write, it will directly feed in where? There. Sir, what are the causes of placenta previa, risk factors of placenta previa? That is the bacha thing. Now, my dear students, tell me what can be the risk factor of placenta previa? Now, placenta previa means that this placenta is in the lower uterine segment. Now, what are the chances this placenta will, more chances of this placenta being on the lower uterine segment when there is which pregnancy? Twin pregnancy, dichorionic, diamniotic, two placentas are there. So more chances of placenta being on the lower uterine segment, triplets, multigravida, these are all the causes of what? Placenta previa. But the main thing is what? Management. So I will tell you the one-liner, you will tell me the management. Listen carefully, okay? A patient is coming to you at 34 weeks with the painless vaginal bleeding. Okay? On examination or USG, the diagnosis of placenta previa is made. What will be your next step? What will be your next step? What will be your next step? 34 weeks, you're expecting lungs are fully mature. Yes, by 32 to 32 weeks, lungs are fully mature. So which management you will give? Question is, a female is coming to you, 32-year-old female is coming to you at 34 weeks of pregnancy. Same question. Now, there is a painless vaginal bleeding, but vitals are stable, everything is fine. What will be the management you will go for? Placenta previa to hai. Painless vaginal bleeding is a placenta previa. What will be your management? Your management will be, sir, wait till how long? 37 weeks. Now, if prior to that, we'll go for conservative management. If vitals not stable, cesarean. And if term pregnancy, cesarean section. Is that clear? So placenta previa at term, what is the management? Cesarean section. Placenta previa before term, preterm, with vital stable, no active bleeding. Conservative management. If placenta previa preterm with vitals not stable, mother is bleeding. Is that clear? Is that clear? Yes. Now, one question was asked from the placenta previa that. Now, placenta in the lower uterine segment is called placenta previa. Yes. So, at 24 weeks, a female came to me. I went for the USG and I saw that this placenta is in a which segment? Lower uterine segment. Now, when the placenta is in the lower uterine segment, what are you expecting? Placenta, what will be your next step? Online people as well, what will be your next step? Let me join this chat. What will be your next step? What will be your next step? Agar placenta previa is there, and this placenta previa, you see at 24 weeks, you go for the USG. Female usually go for the USG, and you see that this placenta is in the lower uterine segment. This placenta is in the which segment? Lower uterine segment. At how many weeks? 24 weeks. What will be your next step now? Why you will abort? Online people, yes? You will continue the pregnancy. Okay, next step. Follow up. Like what you will do next? It's a PYQ. You are solving previous year questions? No. Why? If you would have solved, you would have answered this. 24 weeks placenta, you saw the placenta in the lower uterine segment. Now, sir, what will be the next step? The next step will be you will do USG again at how many weeks? Before 32 weeks. Why? Because placental migration can occur. From lower uterine segment, this placenta can go upper uterine segment. Are you getting my point? This is called as placental migration. So if at 24 weeks you find the placenta previa, you find the placenta in the lower uterine segment, the next step is going to be do USG at 32 weeks, and you are expecting that it can be happen what? What can happen? Placental migration. Okay, next step is that. But if the case will be vaginal bleeding, management and all, then you already know. Okay, now this conservative management that we are doing, it is called a regime called as McAfee-Johnson regime. क्या बोलते हैं इस regime को? What is McAfee-Johnson regime? Admit the patient, arrange the blood, give steroids for fetal lung maturity, and the last step is RH negative pregnancy, give anti-D. This is called as McAfee-Johnson regime. Now tell me the answer of this particular question now. At 32 weeks, placenta previa with vital stable, what will be the most appropriate next step? What will be the most appropriate next step? Yes? Very good. C. So we'll admit the patient for observation and we start the corticosteroid therapy. Now the same question I will write here, 37 weeks. What will be the answer? Caesarean section, right? Yes. The same question I will write what? 37 weeks. What will be the answer? Caesarean section. Okay. And can I discharge the patient? No. Can I discharge the patient? No. Sir, perform a digital vaginal examination? No. Contraindicated. All the antepartum hemorrhage cases, the examination is okay. Chalo. Now let's write what is placenta previa. When the placenta is implanted, in the lower uterine segment, when the placenta is implanted in lower segment. Now, my dear students, based upon the degree of extension, now you already know, sir, depending upon how much this placenta is extended on the internal os, on the opening, okay, it can be of how many types? 4 types, type 1, type 2, type 3, and type 4. So the type 1 is called as lateral. So type 2, it's called as marginal. So type 3, it's called as partial, and type 4, it's called as complete. It's called as complete. But now the type 1, which is the lateral, it is called now what? Low lying placenta. It's called as low lying placenta. What is low lying placenta? 2 centimeter away from the internal os. And what exactly is marginal, partial, and complete now? It's called as placenta previa. Is that clear? Yes. Now you will tell me by yourself what will be the clinical features. What are the clinical features? Very good. So first one is going to be painless vaginal bleeding. What is the next thing? So uterus will be very good. Uterus will be soft and non-tender. Very good. And so the height of uterus is equal to period of gestation. Clear? Yes. Now again, very basics, you know. So after now diagnosing the placenta previa, there are 2 scenarios. So either 37 weeks or less than 37 weeks. So if 37 weeks, that means which pregnancy? Term pregnancy. What is the management? Caesarean? Caesarean section. So if less than 37 weeks, what is the management usually? Expectant management. Clear? Now what is this expected management? McAfee-Johnson regime. Very good. Yes or no? So what is this McAfee-Johnson regime? Admit the patient, arrange the blood, give anti-D if RH negative, and give steroids for fetal lung maturity. Very good. Yes or no? Yes. You will only do this McAfee-Johnson regime when the mother is stable. There is no active bleeding. Are you getting my point? And baby is not in the distress. Okay. Now, there is no risk at all, neither to mother and baby, then you will go for which management? Conservative management. It's called as McAfee-Johnson regime. Is that clear? So write it down. So what is expectant management? So expectant management means you continue the pregnancy. So you continue pregnancy without risk. You continue the pregnancy without a risk. First thing. Second thing is, sir, patient should be stable. Patient is hemodynamically stable. Okay. Next, so there should be no active bleeding. Third, there should be no fetal distress. There should be no fetal distress. Clear? Yes? There should be no fetal distress. And the regime that we follow, so this regime is called as McAfee-Johnson regime. Now, in the options where I have mentioned admit the patient and initiate corticosteroid therapy, I can also write this McAfee-Johnson regime. What was the McAfee-Johnson regime? Admit the patient, give steroids. If Rh negative, give anti-D and arrange the blood. Is that clear? Now, what is this McAfee-Johnson regime? Sir, we admit the patient. So we admit the patient, so arrange the blood, sir, if Rh negative, give anti-D and sir, give steroids for fetal lung maturity. Now, what are the steroids? Beta-methasone, dexamethasone. Beta 2 doses, dexa 4 doses. And what is the best test for fetal lung maturity? That's going to be phosphatidylglycerol in amniotic fluid. So we also check the lecithin-sphingomyelin ratio as well. Is that clear? These are the surfactants, but I will teach you in a detailed test dosage in the coming questions. Okay? So I will not write it here. We'll write in the next few slides. Okay? One more question is that these beta-methasone and dexamethasone, they act on which pneumocystes? Type 2 pneumocystes, because type 2 pneumocystes are the one who release surfactant, and when this drug will act on this type 2 pneumocystes, more surfactant will be released, so the fetal lung will be mature. If surfactant is less, तो baby को क्या होता है? Hyaline membrane disease, है ना? ARDS, that's what you call, है ना? चलो. Is that clear? That is all about the placenta previa. My question to you, sir, what is investigation of choice for placenta previa? And for screening, what is? Chalo, bata do. For screening, yes, online people as well. For investigation of choice, how you will diagnose? Trans-vaginal scan. Screening के लिए trans-abdominal scan. ठीक है ना? Trans-vaginal scan and that is investigation of choice. But we investigate best is that only, na? Screening के लिए trans-abdominal scan. But we usually perform what? Non-invasive procedure. What is that? Trans-abdominal scan. What is the best test for ectopic pregnancy to check? Trouble solver. It's MRI. Do we go for MRI? No. Hana? That's why we go for an SCG. There are invasive procedures as well. Laparoscopy as well. Do we perform laparoscopy for that? We can inflate the abdomen with the CO2, put the two probes and check with the laparoscopy. Where is exactly the pregnancy? हमें पता चलेगा, is the pregnancy in the uterus or in the tubes? But that is an invasive procedure. Rather that we directly go for what? Trans-abdominal scan or beta HCG levels. Are you getting my point? Yes. So investigation of choice can be invasive procedure as well. But then we check whether we have to go for invasive procedure or not. Okay. So here, what is the investigation of choice? Trans-vaginal scan. But trans-abdominal is a screening for placenta previa. If screening test is inconclusive, that time we can go for which test? invasive procedures. Yes or no? Conditions apply. Conditions apply. So that was all about the placenta previa. Is that clear? Is that clear? Yes, speed is okay? Yes? Little bit I will thoda increase. Now tell me the answer of this particular question. Online people as well? ये chats क्यों नहीं आ रहे? What will be the answer of this question, बच्चे? A primary gravida at 37 weeks of gestation reported a labor with a marginal anterior placenta previa, painless vaginal bleeding. Sir, fetal heart rate was normal. The best management option, cesarean section. I just told 37 weeks placenta previa. What is the answer? Cesarean section. Prior to that, what will be the answer? Prior to that, what will be the answer? Expectant management. Chat क्यों नहीं आ रहा है? Online students. Anyone text in the online students? Write down in the chat box. चलो शायद हमें ही नहीं दिख रहा है. Is that clear? Okay, okay. चलो चले. Now next condition. Next condition we will understand first and then we will write. Is that clear? Next condition we'll understand first and then we'll write. Okay. In next condition, tell me what is the next condition? Abruptio placenta. What is abruptio placenta? What is abruptio placenta? Yes. Premature separation of placenta. Abruption, abruptly, suddenly. Are you getting my point? In the word itself says. What does abrupt means? All of a sudden. Now, all of a sudden, this normally implanted placenta, it detaches. It detaches. What is the condition called as? Abruptio placenta. Very good. Now, first thing. So, what can be the reason for this abruption? Fetal? There are no contractions in the abruptio placenta. Uncontrolled hypertension, trauma. If there would have been contractions, तो फिर normal vaginal delivery हो जाता ना, खुद dilatation हो जाता. It is all of a sudden. Woman is all of a sudden normal. There are no contractions and abruptly the placenta detached. Due to what? Trauma, multigravida, hypertension. All of a sudden what happened? This placenta detached. Now when this placenta detached, there are two things. So either when the placenta will detach, the bleeding will come out. Are you getting my point? Either the bleeding is between the membranes, Now, if you see that there are three types, concealed, revealed, and the mixed type. In the revealed one, the bleeding is coming out. In concealed, bleeding is there only. Are you getting my point? Now, what will be the presentation of a patient? Opposite to the placenta previa. Painless over there. Here will be non-tender here will be soft uterus, hard, rigid uterus. Height of uterus corresponding to period of gestation. Height of uterus more than the period of gestation. Presentation is clear. Definition is clear. Types is clear. Yes. What is concealed? Bleeding is not coming out. What is revealed? Bleeding is coming out. Very good. Now, when the bleeding is not coming out, this bleeding, can you see the uterus? ये क्या है? Uterus. This is placenta. Now, this bleeding over here, this bleeding goes into the uterine musculature. कहाँ जाती है? Uterine musculature. There is an extravasation of the blood in the uterine musculature. And when this blood enters into the layer of the uterus, such a uterus is called as covular uterus. क्या बोलते हैं उस uterus को? Covular uterus. So C for concealed, C for covular uterus. One question was asked, which of the following type of abruptio placenta is associated with the covular uterus? What is your answer? Concealed type of abruptio placenta. C for concealed, C for and this is called as covular uterus. When the bleeding is not coming out, this bleeding is going into the muscle layer of uterus, and the classical appearance of this uterus, it is called as also bruised uterus. This bruised uterus or covular uterus is seen in which type of condition? Abruptio placenta. Which type of abruptio placenta? Concealed type of abruptio placenta. Is that clear? What is concealed? What is revealed? One more question they can ask, that the presentation will be given. In the presentation, they will not mention what? They will not mention the bleeding. They will give all the presentation: pain abdomen, tender uterus, okay, hypertension. But which of the following is type of abruptio placenta seen? Answer should be concealed type, because all the things are same with the revealed, but the only difference is patient is not bleeding. So if not bleeding, your diagnosis is concealed abruptio placenta. If bleeding, revealed. If no other type is given and just painful tender uterus with bleeding is called abruptio placenta. Very good. Yes. Now you will tell me the management. Batao. Tell me the management. Again, sir, before term. है ना? Yes. Why you will do cesarean section? See, cesarean section, my dear students, only when the fetus is in distress. Number one thing. Mother is actively bleeding. Second thing. Third thing. Mother is not hemodynamically stable. Sir, other than that, what is the answer? Normal vaginal delivery. But how you will do normal vaginal delivery in abruptio placenta? Tell me. Yes, very good. You will induce the labor. How you will induce the labor? Artificial rupture of membranes. What will artificial rupture of membrane do? Release prostaglandin. Prostaglandin will induce the labor. Sir, can I do augmentation of labor here? No. Why? Because there are no contractions present. Now listen to me very carefully. Now this is point 1, this is point 10. Okay? Point 1 to point 10. When you start from the 0 to 10, this is called as induction of labor. 0 means there are no contractions at all. But when you start from 4, now this point 0 person is coming 1, 2, 3, 4, and it's exhausted. What does this exhaustion means? There are no contractions now. Now from point 4 to I need to go till where? Point 10. That means the contractions are not enough. So I will enhance these contractions. I will give prostaglandins from the outside. So I'm starting from 4 to 10. This is called as augmentation of labor. But in abruptio placenta, female was normal. Yes, there were any contractions? No contractions. So I will go for induction of labor. They will ask the question that in abruptio placenta, will you go for induction of labor or augmentation of labor? Induction of labor. Sir, what is augmentation of labor? When the contractions are not adequate, when the contractions are not enough, and those contraction need enhancement. Such a condition is called as augmentation of labor. Classical example, female is out there. Are you getting my point? Female is out there. You're going for per vaginal examination. So she's 3 centimeter dilated. Okay, so 4 centimeter dilated. Now she's in which phase? Active phase. Now in active phase, there should be a 1 centimeter per hour dilatation. So at 1 p.m., she's 4 centimeter. At 2 p.m., you are expecting how much? 5. At 3 p.m., 6, 7. Are you getting my point? But you going at 5 p.m., she is only 5 centimeter dilated. That means the labor is slow. That means labor is slow. The contractions are not adequate. At that time, you can say that we are going for which labor? Augmentation of labor. Is that clear? Is that clear? What is augmentation of labor? So female is already having some contractions, but they are not adequate. Is that clear? What is induction of labor? From the 0. In abruptio, you are doing from 0. Now, whether it is induction of labor or augmentation of labor, what is the goal? Reaching at point 10. So the ways that you do for induction of labor are same the ways you do for what? Augmentation of labor. Now, if I will go in a detail, give prostaglandin here also, give prostaglandin here also, that is of no use. The main thing, only study what? Which is important. है ना? Otherwise, if you will study everything, are you getting my point? If you study everything, the OB-GYN rather being 150 page, it will be 500 page. But do we need 500 pages? No. There are OB-GYN who are 800 pages. Do we need 800 pages? No. Am I here to make you obstetrician? No. Gynecologist? No. I am here to help you pass the exam. It is not you take my class and go and open the abdomen and take the baby out. No. You will do that in when? When you do the PG. And right now only focus on what? Exam. है ना अब हम अभी से ही obstetrician बनेंगे no sir placenta will be this none of you have seen how placenta is detached because we are foreign graduates hypothetical doctors we just imagine okay placenta is there you expect labor room patient is coming doctor I am in labor no there is nothing like that that is kind of fish market all the female out there screaming out so it's totally different scenario okay pre-exam and post-exam okay so how you will deliver in abruptio placenta normal vaginal delivery with artificial rupture of membranes. Now, what is this artificial rupture of membrane doing? Induction of labor. Okay, so when we strip the membranes, when we puncture the membranes, so they release endogenous prostaglandin. So prostaglandin क्या करेंगे? Contractions or induce करेंगे labor. So can we give the outside prostaglandin? Yes. What are the prostaglandins we give? Dinoprostone. You might have seen if the female is not dilating, what is the gel we give? Prostaglandin. Which gel? Dinoprostone. You take the coscospiculum, open it, put the tube in the cervix, put the gel. What is the gel? Prostaglandin. Now what is dinoprostone? Which prostaglandin? PG? E1 or E2? 2. E1 is misoprostol. Now, examiner will not ask these days dinoprostol or misoprostol. They will ask which prostaglandin, E1, E2, PGF2 alpha. So you have to remember the class of the drug. Okay? You have to remember the class of drug. Is that clear to online people? Yes? All clear? Yes, chalo. Now, term, okay. Now, sir, which condition in abruptio placenta you will go with cesarean section? Fetal distress, mother is unstable, or mother is at risk, then the answer is cesarean section. Other than that, answer is normal vagina. Sir, in preterm, if everything is fine, can we go for cesarean section? Why you will go? In abruptio placenta, the problem is what? Placenta is detached. Are you getting my point? But door is open. What is door? Os. है ना? Os के ऊपर कुछ है. There is nothing on the os. Sir, then why we can go for what? Normal vaginal delivery. Now, one student asked me a question. Sir, if placenta is detached, baby can die? Yes, sir, baby can die, depending upon the grade of abruptio placenta. Now, what is the grading of abruptio placenta? It is called as Page's classification. What is Page classification? Listen first. Sir, grade 0, asymptomatic. Grade 0 is? Then 1, 2, 3, mild, moderate, severe. And a very simple classification. Grade 0 is asymptomatic. 1, 2, 3, mild, moderate, severe. In which of the following will be the fully baby distress and death? Grade 3. Are you getting my point? Now, depending upon what? Classification, mild, moderate, and severe. Any question from abruptio placenta? Any question from abruptio placenta? All clear? Can we write now in 2 minutes? Yes? Before that, answer. Chalo. A 32-year-old pregnant woman at how many weeks? 36 weeks. She present with the abdominal pain, vaginal bleeding, and tense tender uterus. Fetal heart rate monitoring reveals a fetal bradycardia. What is the next best step? Immediate cesarean section. Immediate? Sir, यहाँ पे bradycardia देखा. That is diagnosis of what? Fetal distress. Sir, fetal distress is seen. Doesn't matter what will happen. The only thing will happen cesarean section. In what other condition you will go with the cesarean section? Mother unstable, actively bleeding. Is that clear? Or sometimes in other condition, what happens? Cord entanglement. क्या हो जाता है? Cord entanglement. And in cord entanglement also, what you will answer? Look. Okay, you cut the skin, subcutaneous tissue, then the rectus abdominis muscle directly reach to the uterine cavity. Take the small blade, puncture the uterine cavity, amniotic fluid will come out, do the suction, take the baby, and see why we went for the cesarean section. Can you see in the other hand of the doctor there is what? Suction present over there, because once you open the uterine cavity, okay, to prevent the meconium aspiration, you need to what? Suction. Look at the baby and look at the neck. Clear? Now see, first loop and then the next loop. So what was the indication over here? So the indication over here was there is cord entanglement. There is cord entanglement, which led to the fetal distress, which was the indication for cesarean section. Is that clear? Yes. So any condition, fetal distress, what is the answer? Cesarean section. Chalo. Next. Now let's write what exactly is abruptio placenta. Okay. Abruptio placenta. Now you can guys chat. You can put the message. It's open now to everyone. Now, so abruptio placenta means premature. It's premature separation of normally implanted placenta. Premature separation of normally implanted placenta. Okay. Then followed by that, what are the risk factors? So first of all, risk factor can be hypertension. Okay. Then trauma. Then multi-parous woman. Then previous history of abruption or previous abruption. Is that clear? Yes. Now, sir, we have three types. What are the types? We have concealed, revealed, and mixed. Concealed, revealed, and mixed. Concealed, revealed, and mixed. Now, what will be the presentation of a patient? Painful vaginal bleeding. Okay, so it is usually in which trimester? Third trimester, and there will be dark red color. Okay, dark red color blood, previous abruption. Okay, chalo. This much is clear? Yes? All clear? Anyone, any doubt? Kuch bhi? Yes? All clear? Back people, all clear? Chalo, batao ab. Per abdominal examination, you already know, tell me. Per online people as well, if you have any doubt, ask anything. Yes. What will be the per abdominal examination? You already know. Very good. Tender uterus. Then rigid. Very good. Then height of uterus more than the period of gestation. है ना? लिखो. लिखो. Write by yourself. अरे write by yourself. There is no rocket science. So first of all, uterus is tender and rigid. Okay. Second, sir. Height of uterus more than the period of gestation. Now, one concept here. I will add on this here. Now listen carefully. Female is coming to me. Female is, carefully, female is painful vaginal bleeding. Number first thing. Tender uterus. Number second thing. Ridged uterus. Height of the uterus more than the period of. Fetal parts palpable. Now, abruptio placenta and rupture of uterus, they are exactly same. The only difference is fetal parts palpable. Answer is rupture of uterus. Fetal parts not palpable. Answer is abruptio placenta. When there will be the rupture of uterus, the fetal parts will directly come into the abdomen and you can directly palpate from the outside. Yes, these are the feet of the baby. Why? Because there is a rupture of uterus. Then the rupture of uterus also have type. One is fully rupture of uterus, another is partial. It is also called as, क्या बोलते हैं उसको? Anyone in the comment section? Dehiscence. क्या बोलते हैं उसको? क्या बोलते हैं? पढ़ा है? सुना है ना? Dehiscence सुना है ना? पूरा scar or dehiscence. What is dehiscence? Not all the layers are ruptured. Partially. Are you getting my point? Partially. Okay? Fetal parts are still intact. Still intact. Okay? Uterine dehiscence we call it as. Okay? Fully rupture is complete rupture. Okay? Now, sir, in abruptio placenta, this question has been asked in your exams. Fetal parts not palpable. Please remember, not palpable. And last one, fetal heart sound is not heard. Fetal heart sound is not heard. Fetal heart sound not heard. Good. Now, sir, this type of uterus, it is called as bruised uterus. Yeah? Covalare uterus. Bruised uterus or covalare uterus. What is this bruised uterus, bachcho? So there is extravasation of blood into the uterine musculature. And it is due to which type? Concealed type. Into the uterine musculature. So this is called as covalare uterus. And there is C for covalare, C for concealed type of abruptio placenta. Concealed type of abruptio placenta. Clear? Yes? Uske baad. What is the classification? Page classification. What is the classification? Page classification. So write down in grade 0 as per the Page classification. It is asymptomatic. Very good. In grade 0, write down in the chat box as well, guys. In grade 0, it is asymptomatic. Followed by that, it's mild, moderate, severe. Likho. Sir, it's mild, it's moderate, and it's severe. What is mild? There is simple, sir, pain, abdomen, and bleeding. Okay. Then right first mild. So there is pain plus bleeding. Pain plus bleeding. And fetal heart sound is, sir, normal. Fetal heart sound is normal. Okay. Sir, moderate. Sir, we see the fetal distress. क्या देखेंगे बच्चों? Fetal distress. Okay. Sir, and in case of grade 3 severe, fetal death. Fetal death. Okay. When fetal death will happen, that means patient will bleed heavily. Yes or no? So what are you also suspecting maternal shock. Yes, so write fetal death plus maternal shock plus maternal shock. And sir, pregnancy is a hypercoagable state, so plus minus क्या हो सकता है? DIC. What is DIC? ये तो मुझे भी पता है, full form disseminated intravascular clotting factors can used or reduced. Okay, what else can happen in pregnancy related to the clotting factors? Thrombus can form. What can that thrombus cause? और एक प्रेगनेंसी में कौन सा एम्बोलिज्म होगा? In what embolism can occur in pregnancy, guys? Online people? ये क्या लिखा? AFI. What is AFI? Amniotic fluid embolism. है ना? Pulmonary embolism will be seen in the patient having deep venous thrombosis, or the patient having a big pelvic surgeries, knee replacement, hip replacement. Fat embolism will be seen with not femur, long bone fractures. है ना? Long bone fractures. F for fracture, F for fat embolism. Ear embolism will be seen with the deep sea divers. And in pregnancy, which embolism? Amniotic fluid embolism. है ना? Yes, what is amniotic fluid embolism? Sir, amniotic fluid and its contents, they make what? Thrombus. है ना? That thrombus will go into maternal circulation, causing what? Collapse. Such type of embolism is called as amniotic fluid embolism. Very simple, है ना? Pregnancy is a hypercoagable state. I've already told you. Now this amniotic fluid contents, they will come and combine, and that will go into the mother's circulation, causing collapse. Such type of embolism is called as amniotic fluid embolism. I will teach you also in coming questions. Now, sir, management. In term, if fetal distress, write down by yourself. If no distress, if fetal distress, cesarean section. If no distress, that means vitals are stable. Okay, what you will do? Induction of labor with artificial rupture of membranes, and then you will go normal vaginal. सही है ना? What will artificial rupture of membrane do? They will release. What will prostaglandin do? Induce the labor. है ना? Contractions करके labor को क्या करेंगे? Induce. है ना? This is called induction of labor. देख रहे हो? Membranes को rupture कर रहे हैं ना? This is called as induction of labor. This is called as induction of labor. चलो. Sir, now 34 weeks. She is coming. Sir, in term, सबसे पहले हमने तो cesarean कर दिया. But remember one thing. Now you will tell me, sir did not said. Any case of heavy bleeding, when a patient can go into the shock, what is the first thing? Resuscitation. वो तो पता ही है ना? What is the first thing always? Resuscitation. First thing always is resuscitation. The best management is cesarean section. Any patient going for seizures, what is the first thing? Airway management. Any patient going for trauma, वहाँ पे bleeding हो रही है, what is the first management? Resuscitation. So please do remember this. The examiner can ask, don't directly mark what? Cesarean section. सबसे पहले resuscitation. Silly mistake नहीं करना. That time you will say, sir ने क्या नहीं लिखा? Resuscitation. मैं लिख ही लेता हूँ. Resuscitation. IOL means induction of labor. IOL means induction of labor. Don't search for the full form then. During my time, I was also writing IOL. But when I reach home, what is IOL? I used to Google. वहाँ पे निकलता था International Organization of Labor. So you have to remember the only write short forms when you know the full form. If you don't know the full form, don't write the short form. What is arm? Artificial rupture of. What is NVD? Sir, it is too basic. Yes, it is too basic, but we are same. है ना? I also used to do same, then forget what was the what? Full form. Resuscitation. After that, now at 34 weeks, you have to give the shot. Prior to the 34 weeks, you have to give the shot of what? Steroids. है ना? You have to give the shot of steroids. So right, steroids to mother for fetal lung maturity. ठीक है? Sir, at 34 weeks, if there was no emergency, that means there was no distress, there was no active bleeding, there was nothing, there was no emergency. What is the next step? Continue the pregnancy. Till how long? Till term. If no emergency, continue the pregnancy till term. Sir, if emergency, cesarean section. Very simple. Yes or no? Yes. Now at 34 weeks, there are two conditions. First of all, you will go resuscitation. Then you will give steroids. Now two scenarios. Sir, if stable, continue. If not stable, continue till 37 weeks and do normal vaginal delivery. If unstable, cesarean section. Is that clear? Are you getting my point? Yes. So always, 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 cesarean section is there when the vitals are not stable. If vitals are not stable, hemodynamically unstable patient, irrespective of weak or not, what is the only management? Cesarean section. Yes or no? You have to save mother as well. Yes or no? Yes. Sir, if vitals are stable in abruptio placenta, I will continue the pregnancy till term. Placenta previa term, cesarean section. Preterm, if vital stable, everything is fine, no risk. McAfee-Johnson regime. If vitals not stable, again cesarean section. Is that clear? Is that clear? So write the last line, sir. If no emergency. So rather writing no emergency, can I write if vital stable? Yes. Huh? Still you have to give shots. And it is 34 weeks. It can be prior to that as well. So along with that, you have to give one shot of steroid and what? Deliver. Okay? We don't give full doses. In real practice, when you will see a patient coming with you, we'll give one dose at least for what? Beta methasone. Okay? If lungs are mature, that are fine. But still going on a safer side, we still give what? Steroids. Is that clear? And question will usually mention prior to 34 weeks. Clear? Preterm mein hamesha expect what? Lungs cannot be what? Fully matured. Conditions apply. For example, gestational diabetes mellitus. Lungs are not mature till 34, 35 weeks. That is why we have to give what? Steroids. But again, we have to give steroids only when you are in the hospital. Why? Because steroids will again increase the sugar levels, and GDM patient is already there. Okay? We don't give fully doses, we don't coverage the fully doses, but still we give what? One dose of BTM and then deliver. Because BTM has other effects as well. Chalo, if vital stable, what you will write? Continue. Pregnancy. If unstable, NVD. Is that clear? Is that clear? Chalo. यहाँ पे लिख सकते हो less than 34 weeks. Bas, that will go, that indication of steroids is must. Chalo. That is all about abruptio placenta. Abruptio placenta is clear? Yes. Now what is Vasa previa, last condition? Okay. Answer me this question. A 35-year-old gravida 3 para 2 live 2. Understand the question first. How many weeks of pregnancy? Blood pressure is? Loudly, blood pressure is? High. After 4 hours, she complaining of pain, abdomen, and in between uterine contractions. Fetal heart rate is? Cervix is how many centimeters dilated? Membrane show, blood stained? All of the following can be done except. Yes, all of the following you will do except. What is the answer? A B C D. उनको मत देखो. Give oxytocin and placental delivery. What else? Huh? Guys, we just studied what? Abruptio, placenta. Did I discuss hysterectomy anywhere? No. Sir, it is a condition wrong with the placenta. है ना? Something wrong with the placenta. Why I will take the uterus out? Placenta तो निकलने ही वाला है ना after delivery. So why you will take what out? Uterus out. So all of the following are to be done. Except, why you will do hysterectomy, sir? है ना? Just now for 20 minutes I was shouting about abruptio placenta. From the morning I did not mention hysterectomy. So use your mind. Hysterectomy, why you will do? Now see, what is the main causes of abruptio placenta? Increase blood pressure. How much was the blood pressure? 150 by 100. Second thing, pain abdomen hint. Third thing, membrane ruptured show blood stain lacquer. That means red color amniotic fluid. And red color amniotic fluid indicates hemorrhage. Which hemorrhage? Antepartum hemorrhage. Usually which one? Abruptio placenta. Is that clear? Yes. Now the last one, Vasa previa. What is Vasa previa? What is Vasa previa? बता दो. Yes. Filamentous insertion of cord. And what is Vasa previa? You have studied? Yes, पढ़ा है ना? तो बताओ. Or separating of cord at os. Very good. Yes. Guys, tell me. Online people, what is Vasa previa? Sir, separating of cord at os. Very good. What else? एग्जाम आने वाला है 15th of June को. नहीं, 26th of July को. Tell me guys. Define. Yes. बताओ तो बताओ. डाउट है? ओके. अच्छा तुम देख रहे हो इसको. बताओ क्या है. Okay, listen. अरे chill, be. We have types of placenta. Yes or no? What are the different types of placenta? Marginal नहीं उसमें. Battle door, then succinureate, then bilobed, furcate, filamentous, है ना, circumvallate, है ना? Yes, you have studied this? Yes, sir, we have studied this. Now, sir, if we talk about the different types of placenta, Gyne. Now look at this. Look at this. This filamentous cord insertion. Can you see in the filamentous type of insertion, there are multiple cords? Yes or no? These cords, if they are present at internal os, this condition is called as Vasa previa. Sir, how to remember? V for Vasa, V for filamentous. Are you getting my point? First thing. So second thing is that if the splitting of the cord occurs, now see this cord is splitting in two things here, two lines. If the splitting of the cord occurs at the os, again this is called as Vasa previa. Clear? That is called as type 1 Vasa previa. When which placenta is involved? Filamentous cord insertion. Now we have one more type called as type 2. Type 2 is when which one is involved? Succinureate type of placenta. One big lobe and one small lobe and one big lobe. This is called as type 2 Vasa previa. Are you getting my point? Sir, when this type or this type, it is present at the internal os, the condition is called as Vasa previa. Now this Vasa previa is mainly associated with which bleeding? Fetal bleeding. Now if the fetal bleeding will happen, sir, what will happen to the baby? distress. So what is the classical presentation of a Vasa previa? Painless vaginal bleeding with fetal distress. Is that clear? What is your diagnosis? Vasa previa. Itna samajh aa gaya? Now listen to the one more thing. Sir, in this Vasa previa, when a patient is coming, there can be of two types. One with a filamentous cord insertion. Now look, this is the placenta. This is the cord. This is the umbilical cord coming. यहाँ से यहाँ तक, what is occurring? Splitting of the cord. Yes or no? Yes. And this is placenta. So where are these splitting of the cord present? At the os. It is type 1. Yes. Type 2, big lobe, small lobe. And the connection between the big lobe and small lobe, these vessels are present at the internal os. It is called as Vasa previa with the bilobed. What is the name of the bilobe? Succinureate. Now, my dear students, can there be any expected management here? No, sir. Will there be any conservative management? No, sir. There is only one management. What is that? Caesarean section. Yes. Can I do normal vaginal delivery? See, baby is already in the distress. Yahan pe vessels hai. If I will try to take this baby out from the normal vaginal delivery, the vessels will rupture more, the bleeding will occur more. Baby will die. Are you getting khatam baat? So what is the only management for here? Caesarean section. What is the only management for here? Since you can't see. कहाँ से देखोगे? Comment कर रहे. Can't see. You have already learned it in the main class as well. Now I was discussing about, sir, this Vasa previa. So over here there is vessels from the placenta to the umbilical cord. These splitting of the cord when occurs at the os, the condition is called as, sir, the condition is called as Vasa previa. Again here, sir, this is a one small lobe, this is a one big lobe, and the attachment over here, so these vessels are present at the os, this is called as Vasa previa. Sir, if it is with a one lobe, it is with a one type, the placenta is a filamentous type of placenta. Sir, if it is with a bilobe, the placenta is a succinureate placenta. Is that clear? Yes. And what is the only, these are the unprotected blood vessels. And when you try to deliver this the baby with a normal vaginal delivery, क्या हो सकता है? Rupture of vessels. Baby will die. So what is the only management? Caesarean section. Is that clear? Now, sir. Now, from these vessels, there will be a bleeding coming. Yes or no? Yes. Now, this bleeding can be of how many types? This bleeding can be of how many types? Two types. What is two types? Sir, either it will be from a mother's side or a fetal side. Now, in order to differentiate whether this bleeding is from the mother's side or the fetal side, I will do the test. What is the test called? Alkaline denaturation test. What is the test called? Very good. It's also called as Singer's alkali test. क्या बोलते हैं? Singer's. Sir, if after the test blood is colorless, it is mother's blood. If blood is red, fetal blood. Because fetal RBCs are resistant to alkaline denaturation test. Because fetal RBCs are resistant to the alkaline denaturation test. And what is the most common what is the most common method to perform? Caesarean section. Not most common, the only method to perform is what? Caesarean section. Now, sir, investigation of choice, we also have to do what? Doppler. Why? Because Doppler will tell me about the blood vessels, whether the blood flow to the baby is okay or not. So Doppler is main. All the placental condition, Doppler we do. Why? We do USG with color Doppler. Why? In order to check the blood flow to the baby. Because placenta se hi to jata hai, right? So there can be three scenarios. Okay, I will teach you in the antepartum fetal surveillance. Okay, यहाँ पे उसको नहीं लेके आएंगे. I will coming up. I will teach you how to do the Doppler. What are the findings of Doppler and what are the results and what are the management after getting the results of Doppler. है ना? We need to check how the blood flow is compromised. How the blood flow is compromised. Vasa previa is clear? Yes. Now tell me, Vasa previa. Tell me the definition of Vasa previa. Filamentous cord insertion or splitting of the cord at os. Presentation, painless vaginal bleeding with the fetal distress. Management is only one, Caesarean section. Test, USG with Doppler along with APT test, alkaline denaturation test. If colorful blood, babies. Why? Because fetal RBCs are resistant. If not, mothers. That completes your antepartum hemorrhage. Anyone, any doubt? समझ आ गया? Guys, all good? Yes? Online people, इनको तो आ ही जाएगा, because they have studied once by me only. So same person teaching same thing again and again 20,000 times, obviously. Anyone, any doubt? Lotus root, क्या नाम रखा है? Yes, sir. Guys, all clear? Yes. Are you able to recall everything, online people? Yes, sir. Chale. Now let's recap in just 2 minutes all the types of antepartum hemorrhage, but the main focus on which part? Management part. Okay, you will remember the definitions, sir. Premature separation of normally implanted placenta is abruptio placenta. NBE will not ask that. They are not our relatives. Even if they are relatives, still they don't want you to pass. Yes, है ना? So main thing is focus on the good part, है ना? चलो. So first thing we learned, antepartum hemorrhage. What is antepartum hemorrhage? So bleeding after how many weeks? 28 weeks till the delivery. Is that clear? So antepartum hemorrhage, mainly we have three causes. Sir, placenta previa, abruptio placenta, vasa previa. So placenta previa means when the normally implanted placenta is in the lower uterine segment. Okay. So this normally implanted placenta, which is in the lower uterine segment, at 32 weeks, up till 32 weeks, this placenta can go from lower to upper. This is called as placental migration. Now, if the examiner will ask me the question at 25 weeks, I have diagnosed it in the lower uterine segment. What is the next step? Sir, I will do USG again at how many weeks? 32 weeks, because I can expect the placental migration. Is that clear? Now, investigation of choice for placenta previa is a TVS, but screening we perform trans-abdominal scan. Is that clear? Followed by that, so we have 4 types as per the old classification: lateral, marginal, incomplete, complete. But as per the new classification, we have only 2 types. Either the placenta is what? Low lying. That means how many centimeters away from the os? 2 centimeters away from the os. Or either the complete placenta previa. Is that type 2, 3, 4 is called now what? Complete placenta previa. Followed by that, sir, the placenta previa presentation of a patient: painless vaginal bleeding, soft uterus, non-tender, and height of uterus corresponding to the period of gestation. Okay, and management, 2 things. Sir, 37 weeks, the management will be 37 weeks, cesarean section, badam khaya karo. Cesarean section, less than 37 weeks, expectant management. Sir, I will only go with the expectant management when the patient is having stable vitals. Along with that, patient will not have any risk. Okay? If risk, cesarean section. If not, McAfee-Johnson regime. What is McAfee-Johnson regime? Admit the patient, arrange the blood, give steroids for fetal lung maturity, and RH negative if give anti-D. Is that clear? Yes. Followed by that, we discuss about abruptio placenta. What is abruptio placenta? Separation of normally implanted placenta. So what are the main 2 reasons? Yes, what are the main 2 reasons? Hypertension and trauma. Is that clear? Yes. Now tell me, as per the classification, it can be having a different types: grade 0, grade 1, 2, 3. Classification: grade 1, mild, moderate, severe. Types of abruptio placenta: concealed and revealed. What is concealed? Bleeding is not coming out. And what is revealed? Bleeding is coming out. In concealed, when the bleeding is not coming out, this bleeding goes to the uterine muscle layers, giving the rise to the which type of uterus? Covulate type of uterus. What is covulate type of uterus? Bruised uterus. Is that clear? And in revealed, bleeding is coming out. What will be the classical presentation of a patient? Painful vaginal bleeding. Number first, tender uterus. Number third, height of uterus more than the period of gestation. Is that clear? Fetal parts not palpable. Is that clear? Yes. Now, any condition, mother is at the risk, vitals are not stable, your classical answer is going to be cesarean section. But sir, if everything is fine, vital stable, I will go with the normal vaginal delivery with artificial rupture of membranes. They will induce the contraction and further induce the labor. So can I say I'm going for the induction of labor? Yes. So I'm going for induction of labor. Is that clear? Is that clear? Sir, less than 34 weeks, everything is fine. Continue the pregnancy till term. Is that clear? Followed by that, filamentous cord insertion at os or splitting of the cord at os. The condition is called as Vasa, painless vaginal associated with fetal distress. There is only one management, that is going to be cesarean section. Type 1 is associated with filamentous cord. Type 2 is associated with two lobes, succiunuriate type of placenta. We do the test called as Singer's alkali test. If colorless, if colorful, that completes antepartum hemorrhage. Sir, any rocket science? No. Sir, do you teach anything extra in the normal classes? No. What is the difference? Speed. Is that clear? Yes? Chalo, likhte hai ab. Online people, everything clear? Anyone doubt? No, sir. Chalo. Guys, clear everything? Yes? Now, will you be able to answer? Yes? Main focus on the management. See, एक तो period of gestation देखो पहले. First thing you look at period of gestation. Second thing vitals. Third presentation. That's all. है ना? Tell me what are the indications of cesarean section so far? Complete placenta previa at term, vitals unstable, and Vasa previa. Anything else I mentioned about cesarean section? No. The easy way to answer this obstetric questions is remember the conditions of what? Cesarean section. Easy to rule out. You only remember what are the conditions, we go for what? Cesarean section. Okay, there are only 5 to 6 conditions. I will tell you one by one all. And in gynecology, remember the condition, you go for what? Hysterectomy. So it is very easy then to answer the question. Rather remembering all the things, when you complete your revision, make one note, conditions for C-section. Then write conditions for hysterectomy. It will be so easy for you because in gynecology, most of the conditions at the end, the treatment is what? Hysterectomy. Because if the family is complete, go for hysterectomy. Hai na? These are the like hints or these are the easy shortcuts. Okay, chalo, write it down. Vasa previa. Vasa previa. So in Vasa previa, answer me the question. A 28-year-old woman at 34 weeks of gestation, she is coming with a painless vaginal bleeding and fetal bradycardia. On ultrasound, there is a filamentous cord insertion with a fetal vessels crossing the internal cervical os. What is the condition? Vasa previa. What is the condition? Vasa previa. है ना, यहाँ पे क्रॉस कर रहे हैं ना दोनों जगह पे. They are crossing at both the places. Yes. So what is the diagnosis? Vasa previa. V for Vasa, V for filamentous. याद रखना. V for Vasa, V for filamentous. So write it down, sir. Yes. Answer, guys. Everyone, write it down. Vasa previa is defined as filamentous cord present at os. Filamentous cord present at os, or splitting of os, splitting of cord at os. Got it. Now, what is the presentation of patient, bache? Painless vaginal bleeding. Okay, with fetal distress, with fetal distress, but there is no tenderness. Yes or no? Yes. So diagnosis you will do TVS with color Doppler is very important. Why? Whenever the condition of distress is seen, you have to check the blood supply. Yes or no? Yes. Followed by that, sir, we can also go for which test? APT test, alkaline denaturation test. Sir, the alkaline denaturation test is also called, क्या बोलते हैं इसको? Singer's alkali test. Now, write it down. So, this test helps us to distinguish between maternal and fetal blood. If red, fetal. If colorless, maternal. Test helps us to distinguish between maternal and fetal blood. Maternal and fetal blood. So fetal RBCs are resistant to alkaline denaturation test. That's why if it stays red, it is which blood? Fetal blood. And if colorless, maternal blood. What will be the management? The management is going to be cesarean section. The management is going to be cesarean section. Clear? That's all about antepartum hemorrhage. Answer this. A 25-year-old woman at 32 weeks, diagnosis of Vasa previa. What is the preferred method of this situation? A, B, C, D. A, B, C, D. What is the answer? B. What does elective mean? Planned. Because I know the only treatment for Vasa previa is what? Cesarean section. So I will plan the cesarean section at 34 to 36 weeks. Emergency karenge nahi. Why? Because no emergency is there in the question. It just mentioned that she is diagnosed with Vasa previa. What is elective surgery? When you plan this surgery. Are you getting my point? For example, patient is having what? Appendix. If rupture is there, we go emergency appendectomy. Hai na? If mantrals is more, leukocytosis is high, fever is there, we give antibiotics first for 2-3 days, okay, at least to decrease the infection. Then we write elective appendectomy. That we are planning this. Are you getting my point? So that is what elective cesarean section. Okay, na? Sometimes basic doubts can be there, no problem at all. Antepartum hemorrhage is clear. Anyone any doubt? Yes. You study one slide of Vasa previa, one page of Abruptio placenta, and one page of placenta previa. These 2.5 pages will include all the questions of antepartum hemorrhage. Everything. When I say everything, that means everything. But conditions apply on the mood of NBE. If now they will invent something new, that new will come in where? New notes. That's how the inauguration of 2.0, 3.0, 5.0 happens. Even not the any teacher doesn't know that what NBE will ask. And when the NBE will ask, that's how they will do what? Add on in your new notes, PYQs. And now two things they will do. Add the previous questions and change the font. Rest everything is same. So what you will do? I will do the same. Which of the following is the most probable cause for bleeding per vaginum occurring 24 hours after the delivery? What is the answer? अरे डी कहां से हो गया? B or D? B. What is the answer? B. What is B? B is going to be retained of placental bits. B is going to be retained of placental bits. वो भी सर ने यूट्राइन एटोनी तब लिखा है जब बिफोर 24 आवर्स होगा. ये आफ्टर 24 सर है. That is about the primary postpartum hemorrhage. When the primary postpartum hemorrhage happens, that is called as what? Within 24 hours of delivery. At that time, the cause is atonic uterus. But after 24 hours, what is the cause? Retained placental bits. Is that clear? Yes? Can we discuss now postpartum hemorrhage? Yes. What is postpartum hemorrhage? After the delivery till 12 weeks. Now, this postpartum hemorrhage is a complication of which stage of labor? फोर्थ कहां से हो गया, कौन फोर्थ बोल रहा है? फोर्थ में तो ऑब्जर्वेशन है, वो घर पे बैठी है. आफ्टर थर्ड स्टेज ऑफ लेबर है ना, ये लिख रहे हैं थर्ड स्टेज ऑफ लेबर. व्हाट इज थर्ड स्टेज ऑफ लेबर? ये देखो, ये देखो, डिलीवरी ऑफ बेबी टू द डिलीवरी ऑफ placenta. In they have gotification, don't worry. Delivery of the baby to the delivery of the placenta. It usually occurs for how many minutes? 30 minutes, 10 to 15 minutes, up to 30 minutes. Okay, 10 to 15 is the ideal time, but it can go up to how many minutes? 30. Sir, if it is more than 30 minutes, I call it as more than 30, I will call it as prolonged third stage of labor, or it is also called as, look, it is also called as retained placenta. It's also called as retained placenta. Now listen to me. Okay. What is this? Placenta. What is this? Cord. Okay. What is third stage of labor? How many stages of labor we have? 4. ये एक कम क्यों कर रहे हो तुम यार? How many stages of labor we have? 4. What is first stage of labor? From the onset of contraction to the dilatation. What is second stage? From dilatation to the delivery of the baby. What is third stage? From delivery of the baby to the delivery of the. What is fourth stage? Observation stage. जो आप भूल गए थे, है ना? Fourth stage is observation stage. Most important stage is third stage. Sir, why? No, not important, because postpartum hemorrhage is occurring. Because the delivery of the placenta is taking place. That's why it is most important. And all the complications started from which stage of labor? Third stage of labor. Now, when I try to deliver this placenta, what is this? इधर 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 वहां पेरिनियल टीयर लिखा हुआ है. What is this? Placenta. What is this? Cord. When we try to deliver this placenta, we have to slowly remove the cord. Are you getting me? Put the pressure and move it like inward, outward. Are you getting my point? This is called as control cord traction. क्या बोलते हैं इसको? You put the left hand on the pubis, abdominal part, and then move inward, outward. This is called as control cord traction. Now, if I will remove all of a sudden this cord, what will happen? Lot of things will happen. So first of all, bleeding will happen, called as postpartum hemorrhage, only when it exceeds 500 ml in the normal vaginal delivery, 1000 ml in the cesarean section. So second thing, sometimes this placenta is attached to the uterus so deep that along with the placenta, what is coming out? Uterus is coming out. Such a condition is called as uterine inversion. Second complication. Third complication, mother is bleeding. Shock. So what are the complications of third stage of labor? Postpartum hemorrhage, uterine inversion, shock. Are you getting my point? Yes? Yes or no? Yes. Now, in order to prevent these complications, we have AMTSL. What is AMTSL? Active management of third stage. Now, sir, this stage was so important. That's why we have which stage of labor management? Third stage of labor management. Yes or no? Now, how many steps we have? 4 steps. Very important. First step is give the which drug? Uterotonic agent. What is uterotonic agent? Oxytocin. Sir, what is oxytocin doing? It is maintaining the tone of uterus, because the most common cause of postpartum hemorrhage is atonicity. Now, there are 2 ways to learn OB-GYN. One way to learn is remember directly. Gotification. Sir, PPH, atonic uterus. Second way of learning is how exactly it came from. From the third stage of labor, you have to understand the active management of third stage of labor, then the steps. When you understand the first step, that it is maintaining the tone of a uterus, we are giving uterotonic agent. That's the time you will understand what? Why atonic uterus is the most common cause of primary PPH. So understand the full process. First step is administer the uterotonic agent. What will uterotonic agent do? Maintain the tone of uterus. That is why prior to the delivery, we give a shot of oxytocin to the mother. Are you getting my point? Yes, in order to prevent complication. What is the complication? Inversion, Postpartum hemorrhage, shock, even amniotic fluid embolism. Yes or no? Yes. Sir, second step is going to be delayed cord clamping. Second step is going to be delayed cord clamping. Now we have delayed cord clamping, early cord clamping. What is early? Within 1 minute of delivery. Less than 1 minute. What is delayed? 1 to 3 minutes. Is that early? Kab karenge hum? What are the conditions? We'll go for early cord clamping. Birth asphyxia, neonatal resuscitation is needed. Are you getting my point? RH negative pregnancy. Why we are going in RH negative pregnancy? Early cord clamping. Yes, sir. The earliest we do so that the blood will not mix with the mother. Because if the more blood will mix with the mother, more antibodies. Are you getting my point? Yes. And the next pregnancy, they will. Yes. No, in RH negative pregnancy, if we'll go, why we go for the early cord clamping? Because we need to prevent the mixing of blood. Because if the mixing of blood will go, there will be antibodies against the RBCs. Yes. So in order to prevent that, we have to go for early cord clamping. Then I will tell you later on how this hemolysis takes place, how to dissolve this, what are the complications, erythroblastosis fetalis, hydrops fetalis, what is NTD, how to give, when to give, later on. But at least remember the conditions of early cord clamping: birth asphyxia, neonatal resuscitation is needed, and RH negative pregnant. Delayed cord clamping, lot of reasons. What if the baby is having fetal anemia? More blood will pass. Are you getting my point? Third thing, yes, heart disease as well. Heart disease also for the early cord clamping. Third condition, third step, you will go for control cord traction. What is the control cord traction? You have a control on the cord and slowly, slowly what? Detach it. Now, my dear students, listen to the condition, listen to the carefully. Sometimes this placenta, what is this? Uterus. What is this? Placenta, and this is cord. Okay. Sometimes this placenta over here, it goes inside uterus. Then it goes more inside. Then it goes more inside. Now at this point, bache, we have a layer called as Nita Bush layer. What is the layer called as? Nita Bush layer. This layer is a fibrinoid layer. This is a fibrinoid layer. When this layer is absent, this placenta is going inside. Now, due to the abnormal decidua basalis and this Nita Bush layer, the placenta is going, ma'am, where? Inside, inside, and inside. When the placenta is going inside, it is easy to detach the placenta or difficult? Yes or no? Such type of placentas are called as adherent placenta. क्या बोलते हैं इनको? It's also called as placenta accreta spectrum. It's also called as placenta accreta spectrum. So we have increta, accreta, parcreta. Are you getting my point? Yes or no? Increta, accreta, parcreta. First one, we have accreta. It's attached to myometrium. A is accreta, A is attached. I, it is invading the myometrium. Increta. P, parcreta. Are you getting my point? P for parcreta, P for pelvic structures. Now, when I try to remove this placenta, when I try to separate this placenta, if the patient is having an adherent placenta, if the patient is having which placenta? Adherent placenta. Along with the placenta, what is coming out? Uterus is coming out. Why? Because sir, placenta was invading so much inside, I was not able to deliver it. That's why, along with the placenta, what is coming out? Uterus. So this is before the placental separation. After the placental separation, uterus will be like this. What is coming out? This part. Uterus. Are you getting my point? This is called as inversion. What is this? Inversion. Now, inversion, what is outside? In prolapse, what is outside? Uterus. What is the difference between prolapse and inversion then? In both the condition, what is outside? Yes or no? Yes. Look. What is this? What is this? Uterus. What is this? What is this? Inversion. What is this? Turning upside down of the uterus is uterine inversion. So what is the management? Johnson's maneuver. Simple. Yes or no? What is this? Uterus. Anna, what is this? Uterus. It will descend down. This is called as prolapse. This is called as prolapse. Are you getting my point? Yes, the support of the uterus in inversion is intact. Uterus does not leave the support. It's not weak in the support. Ligaments are tight. Everything is fine. But in case of prolapse, what is happening? The weak support of the uterus, levator ani muscle, the transcervical ligament, McEnroth's ligament, uterosacral ligament, they get weak. And eventually, this uterus is coming down, 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 and down. Are you getting my point? When the descending of uterus is down, step by step, this is called as uterine prolapse. But turning upside down of the uterus is called as uterine inversion. Are you getting my point? Yes. Now from your simple understanding, when there is a turning upside down of the uterus, this is a Johnson's maneuver. Easy way of what? Treatment for what? Uterine inversion. Now in this condition, if it is going down, 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 prolapse, you will ligate it up. Are you getting my point? Depending upon the age. If elderly, go for the hysterectomy. If middle or young woman, go for the Manchester repair. Okay. And if she's so young, nulliparous, go for the sling surgeries. That is the prolapse and uterine inversion. Do you understand the idea? Third, last one, assessment of uterine tone. So active management of third stage of labor is taking care of the complications like PPH, uterine inversion, and shock. There are 4 steps. The first one is going to be you administer the oxytocin. Second one is going to be delayed cord clamping. Third one is going to be control cord traction. And fourth one is going to be assessment of uterine tone, earlier known as uterine massage. Earlier known as uterine massage. है ना? Yes. Now, my dear students, giving oxytocin prevent postpartum hemorrhage. Yes, because atonic uterus. Sir, control cord traction prevents uterine inversion. Is that clear? Is that clear? Yes. Now, in order to prevent these complications, the best question can ask, the best method to prevent postpartum hemorrhage is what? AMTSL. What is AMTSL? Active management of third stage of labor. Forget everything. At least you know from where exactly postpartum hemorrhage is coming. Exactly you know from where exactly uterine inversion is happening. So if we handle the third stage of labor carefully, what will eventually happen? No complications. Na to PPH hoga, na to inversion hoga, na to shock hoga. Yes or no? Yes. And what is the main reason to strictly perform the AMTSL? To decrease the maternal mortality ratio. To decrease the maternal. What is the current maternal mortality ratio? 93 as per SRS 2025. New update. Guys, online people, in the PSM rapid revision, I will add all the new values for maternal mortality ratio, IMR. We have crude death rate, crude birth rate, because recently in the PSM, so many updates are there, okay? So when we'll have a PSM rapid revision as well after 15th, okay, depending upon my free time. So we'll have a complete PSM revision like this as well. So at that time, I will discuss all the what? All the recent updates, online students as well, okay? Chalo. Can we write now? Yes. Now, do you understand where exactly this PPH came from? कहाँ से आया? Third stage of labor. Third stage of labor को क्या बोलते हैं? 10 to 15 minutes usually. If it's more than 30 minutes, I call it as prolonged third stage of labor. Yes. Now, our next topic are related. PPH, uterine inversion, and the shock and all. I have already discussed. Now, we just have to what? Right. Is that clear? Do you understand exactly? Anyone, any doubt? Yes. One question in your TND is also asked. Out of the following, which is wrong about the AMTSL? So rather mentioning early cord clamping, rather mentioning delayed cord clamping, they mentioned what? Early cord clamping. Yes or no? Yes. So remember, it is delayed cord clamping, not the early cord clamping. They can mention which of the following is incorrect about AMTSL. So they will give 4 steps. Okay. So in second step, it is delayed cord clamping. So they will mention what? Early cord clamping. मैं क्वेश्चन भी यहाँ से बता रहा हूँ, आंसर भी यहाँ से बता रहा हूँ. और तुम वहाँ पे क्या मारोगे? यूट्राइन मसाज. मुझे पता है ना. मैं यहाँ पे बोलूंगा कि पेशेंट के वाइटल स्टेबल नहीं है, सिजेरियन सेक्शन मारा. बट तुम वहाँ पे क्या मारोगे? वेट एंड वॉच. सर ब्लड प्रेशर 150 पे 100 ही तो था, अब कितना होना चाहिए था? 200 होना चाहिए था क्या? नो. इज दैट क्लियर? चलो. नाउ पोस्ट पार्टम हेमरेज. Now, what are the definitions of postpartum hemorrhage? Tell me. Bleeding more than 500 ml in normal vaginal delivery, and in cesarean section more than 1000. Very good. Sir, primary PPH within 24 hours, secondary PPH after 24 hours. Sir, primary PPH most common cause atonic uterus. Secondary PPH most common cause retained placental beds. Now listen carefully. Sir, in primary, in postpartum hemorrhage, mild, moderate, severe, 500, 1000, 1500 ml of blood. Main reason is what? Causes. Now listen first causes, then we will write causes. What are the causes of postpartum hemorrhage? 4 T's. What are the 4 T's? बताओ. ये ना लिखा हुआ है. Tone, trauma, thrombin and tissues. Okay, now one by one. What is tone? What is atonic uterus? When the tone of the uterus is decreased. Which condition the tone of the uterus will decrease? When the uterus is big. When the uterus is, which condition uterus will be big? Twin pregnancy, polyhydramnios, gestational diabetes mellitus, big baby, infection like choreo, amnionitis. These are all the condition uterus is big. So when the uterus is big, tone is decreased. Chances of postpartum hemorrhages increase. That's why I am giving oxytocin to maintain the tone of the uterus. Ab relate ho gaya? Yes. Second is trauma. Trauma kab hoga? Opening is small, baby is big. Some people being over smart, they want to deliver it through normal vaginal delivery. And in between, there is obstruction. When the obstruction is there, we are using instruments. And those instruments have a high chances of perineal tear, uterine rupture, lacerations, or hematomas. These all conditions will predispose to the postpartum hemorrhage. Which cause? Traumatic cause. Very simple, sir. Opening was small, baby was big. And when we try to deliver this baby with a normal vaginal delivery, what occurred? Obstruction occurred. And when the obstruction occurred, we use instruments. There are chances of perineal tear, rupture, hematomas. These all predispose, laceration, these all predispose to the traumatic cause of postpartum hemorrhage. Then thrombin deficiency. If the blood clotting factors are what? Reduced. They will all cause which cause? Thrombin deficiency cause of the PPH. It is very less likely, you will see. Why? Because before every surgery, we go for PT-INR. Every surgery we check, are the clotting factors normal or not? अगर नहीं होते तो हम उसी हिसाब से देते हैं. Platelets are less, we give fresh frozen plasma or single donor platelets. We give accordingly. That's why these thrombin deficiency is less likely to happen. Is that clear? Yes. Followed by that, thrombin deficiency, we can have von Willebrand disease. We can have idiopathic thrombocytic purpura. We can have hemophilia, rarely, hemophilia A, B, C. Factor 8, 9, 11. Factor deficient. A, B, C, 8, 9, 11. So these are related to the clotting factors. That is thrombin deficiency. Is that clear? Followed by that, tissues. What are the tissues? For example, this is when I deliver this placenta, small tissues of placenta, they remain inside. They remain inside. These are called as RPOCs. When you see a radiologist doing a USG of a post-delivered woman, she will write RPOC. What is RPOC? Retained products of conception. Okay, he will write 20 cc, 30 cc, 50 cc, depending upon the volume. Okay, now these tissues inside, when they cause a bleeding, that bleeding is an active bleeding? No, sir. That bleeding is after usually 24 hours. Because usually mother delivered, she will be fine in 24 hours. After 24 hours, when she will go home, she will see bleeding. That bleeding is usually due to what? Retained products of conception and is called as secondary postpartum hemorrhage. That is why after a delivery, we give a drug misoprostol with a trade name Cytolog. Kyun? Whatever debris, whatever small tissues are inside, the misoprostol will expel them out. Are you getting my point? Even in the abortion, in a complete abortion, why we give misoprostol? all the things that are inside, they will come outside. Now, sir, it's a medical management. If the retained products of conception are more and more, that's why we go for curettage. That's why we go for curettage. है ना, करते हैं ना? अगर अंदर small tissues ज़्यादा है, तो what we do? Curettage. Is that clear? Yes. So what is the treatment for secondary postpartum hemorrhage? Sir, do USG. If retained product of conception are more, do curettage. Yes or no? Yes. If you do excessive curettage, what will happen? Asherman syndrome. What is the another name for Asherman syndrome? Another name for Asherman syndrome. वहां पे additions होते हैं, right? It's Synique, uterine Synique. What is the treatment for Asherman syndrome? Additiolysis. Is that clear? Is that clear? समझ में आ गया? Yes. What are the 4 causes? Tone, trauma, tissue, thrombin deficiency. So tone, over distension of the uterus, decreased tone. Trauma, laceration, tear. Thrombin, ITP, VWD, and hemophilia. And tissues, retain products of conception. Now let's write it down. Definition. Treatment हम बाद में करेंगे इसको, पहले लिखो. What is the definition? Sir, blood loss in normal vaginal delivery more than how much? More than 500 ml. More than 500 ml. Sir, blood loss in cesarean section more than 1000 ml. Sir, it is easy to see postpartum hemorrhage? No, it's very difficult. Patient can die in just couple of minutes because patient goes into the shock, injury happened, है ना? What is the complication after the postpartum hemorrhage? Shock के बगैर complication. Shock तो वहीं पे होगा ना actively. किसका hypoxia? वो देखो डॉक्टर साहब ने लिखा. Yes, triple A is right. What is the answer? Pituitary necrosis. Yes. What is the answer? Sheehan syndrome. Always remember this. Complication usually in the pregnant ladies after the postpartum hemorrhage is what? Sheehan syndrome. So what is Sheehan syndrome? Postpartum pituitary necrosis, you can say, or postpartum pituitary infarction. What is infarction? Loss of blood supply. Now when the hypoxia occurred, prolonged hypoxia will lead to ischemia. Ischemia hoga. Prolonged ischemia will lead to necrosis. Now pituitary necrosis happened. Yes, ma'am? Yes. Now all the hormones coming from pituitary will be decreased. Now FSH and LH is coming from pituitary, bolo anterior part. Chalo anterior part of pituitary. ठीक है ना? And antidiuretic hormone is also coming from pituitary. Prolactin is also coming from pituitary. है ना? Yes. All these hormones will be decreased. When the FSH and LH will be decreased, will there be progesterone and estrogen? No. Will there be bleeding? No. Patient will complain of amenorrhea. But now, sir, after the baby delivered, mother is usually having amenorrhea. Which amenorrhea? Lactation amenorrhea. So classical question was asked, what is the first sign of Sheehan syndrome? What is the first symptom the patient will present with a Sheehan syndrome? Galactorrhea, any failure of lactation. Yes, क्या आएगा first symptom? Failure of lactation. क्यों आ रहा है failure of lactation से? Because prolactin ही नहीं था. Because there was no prolactin. And prolactin is coming from where? Pituitary. So amenorrhea is normal after the baby delivered. Yes or no? Why? Because lactation amenorrhea method. But now this mother is not presenting due to what? Amenorrhea. She's saying, doctor, I'm not able to lactate. I'm not able to lactate. Is that clear? So what is the first sign? What is the first classical symptom? Failure of lactation. And what will be the treatment? Give hormones. What are give the hormones which are deficient? FSH, LH, and substitute the hormones. If the prolactin is more, at that time patient can complaining of what? Galactorrhea. Nipple discharge hota hai at that time. If the prolactin is more, what is the inhibitor of prolactin? Dopamine. So what is the drug you will give? Dopamine agonist or antagonist? Agonist. Same action. What is the drug you will give? Cabergoline, bromocriptine. Yes or no? Yes, that is a treatment in hyperprolactinemia. So who is the master in females? Pituitary. Why females are female? Because of pituitary. अगर FSH LH नहीं आएगा, estrogen progesterone नहीं आएगा, bleeding नहीं होगी, ovulation नहीं होगा, conceive नहीं होगा. Are you getting my point? Yes. So remember these two syndromes, Sheehan syndrome and Asherman syndrome. Is that clear? And Sheehan syndrome, why in pregnancy we are studying? Because usually it is with the bleeding loss. It can occur in other females also, जिसको bleeding loss होगा. But pregnancy में mainly associated with postpartum hemorrhage. Is that clear? So Sheehan syndrome is also called as post-pituitary necrosis or postpartum infarction or hypopituitarism. क्या बोलते हैं और hypopituitarism or pituitary apoplexy. Pituitary apoplexy. Lot of things. It's called as Sheehan. What is the sign on MRI? MRI पे एक sign मिलती है. There is a bulging of this pituitary over the optical chiasm. Pituitary ring sign. Rising sun sign उसमें दिखती है. Okay. चलो. Followed by that. So what is Sheehan syndrome? You already know. What is Sheehan syndrome? Postpartum pituitary necro. And what is the first classical symptom? Failure of lactation. What is the treatment? We substitute the hormones. Okay. Now second part. Okay. Bleeding loss in normal vaginal delivery is going to be postpartum hemorrhage. In case of cesarean section, when it exceeds more than 1000 ml. Okay. Now mild PPH. It's